We'd like to get the program started. We are very respectful of your time and know that you're here to hear and learn everything we have to offer in this program. So if we could get your seats and get comfortable, not too comfortable. We want you to be awake. Come on in. That's good. Everybody's quiet. I love it. Find a seat, folks. Thank you. Okay, great. All right. Good evening. How are you? Good, I hope. Well, I can tell you that I can't think of a place I'd rather be on a Tuesday night in June, a hot Tuesday night, than here. And I really mean that. My name is Dawn Pearl-George, and I have the honor and privilege of being the Executive Director of the MACULAR Vision Research Foundation. We're thrilled to be here in Delran Township, and thank you to Elvina Wilson and many others, of which we'll thank at the end, for having us here, to the Township Council, the Resident Council. Some of the members are here. I had the pleasure of meeting them, the Recreation Council, sorry. So thank you very much for having us. We're just over the bridge in right outside of Philadelphia in West Conshohocken is where our headquarters is located. So it's a quick ride, even today. Before we're going to get started, I have a few housekeeping items that we're going to go through very quickly. If you have your smartphone or your cell phone with you, will you do us a favor and make sure it's on silent? Really appreciate that, because you're not going to want to miss anything. I guarantee you. Okay? So if you could do that real quick. Also, I want to give you a little lay of the land. Today, or tonight, I should say, is interactive. And what I mean by that is this is a dialogue and a conversation between you and the presenters that we are going to have on our program tonight. So the reason we make it that way is because we know at MVRF, Macular Vision Research Foundation, that those of you particularly who have macular degeneration or low vision, do not get enough time to get the answers to the questions you have, right? So this is the venue, this is the place to get the answers to your questions for your own situation. If myself or one of our expert panelists or presenters doesn't know the answer, I promise to you that we will get you the answer, okay? So that's that piece. So we're going to encourage interaction, okay? You're going to hear a presentation. This is not just a lecture. You're going to hear a presentation, and then after each one of those presenters will be a time to ask questions. It's a Q&A session, okay? So, a couple really important things. How's the lighting? Do you need more light? Yes? A little more light? Maybe if Colin can turn the lights up? You know better than we do. Okay? Where's Colin? Here he comes. Okay, so we like you to tell us what feels right. Okay? We also understand that not all of you can see the PowerPoints or the video, but how's that? Is that better? No? That's worse. The glare's worse. Yeah? How's that? Are we good like that? Okay, we got it, Colin. Thank you. Also, if at any given time you can't hear a presenter because these people are really good at what they do, but sometimes they put the microphone way up here and eat it, and sometimes they have it way down here and you can't hear them because they're excited about what they have to talk about with you, like I am. So say I can't hear. Don't be shy. Okay? Does that sound good? Okay. Here's the other thing. You're going to hear a little bit about us. I'm really facilitating the conversation. My role as Executive Director of Macular Vision Research Foundation is to bring, and my team to bring this to you, okay? So we need you to do a couple things though, and this is our hope for you, that when you walk out of here tonight, and it's probably still going to be light out because tomorrow's the longest day of the year, right, or today, you know one or two things that you didn't know when you walked in, okay? And the other thing we hope and we want you to do is to tell every single person you know about us. That's it. It's pretty simple. Tell everybody at breakfast tomorrow morning, or while your coffee at the diner, while you're hanging out with your buddies. Tell your family, tell everybody about us. That would be our biggest wish. Okay? Sound good? Yeah. All right. We're going to play a quick video to tell you more about the Macular Vision Research Foundation. We're going to bring Maggie up to get that started.
Macular degeneration is slowly robbing the sight of 15 million Americans. By the year 2020, this number is expected to be more than 20 million people. But we see a clearer future. We know a cure is on the horizon. Over the past 20 years, MVRF has given more than $22 million to the top scientists conducting the most credible and promising research around the world. For decades, macular degeneration was a mystery, something that happened to people as a part of aging. Now, because of MVRF-funded research, scientists know the nature of AMD. They are pioneering leading-edge genetic discoveries, plumbing the very depths of this devastating disease. Our work is fueling even more discoveries. Through gene therapy, we are now reversing childhood blindness and continue to make headway in advanced treatment methods for wet and dry AMD. We see macular degeneration going the way of polio and smallpox, a relic of the past, a footnote of history. We believe we're closing in. We're working every day so millions of people can keep their precious vision. It's the reason our founders, the Lotman family, started MVRF, where 100% of every dollar donated goes directly to research in the field. That's a vision we can get used to. That's a world we can believe in, because believing is seeing. MVRF is a 501c3 public charity, and we rely on support from believers like you. Thank you.
Okay, that's a little bit about us. How many of you knew about us before you came tonight? Okay, few. Good, because we know we're in the right place when not a lot of people know us, because after this, you're all going to know about us, right? I'm going to set the stage before we bring Dr. Brilliant up, and yes, that is his name, Dr. Brilliant, and we love him, and he's lived his entire life with that name, so he's heard it all, right? But let me set the stage a little bit. How many of you have wet macular degeneration? So you get the injections. Okay, what do you think, guys? About a third of the room? A little less? Okay. How many of you have, are you watching, doctor? How many of you have dry macular degeneration? Okay, more. Okay. How many of you have both? Dry in one eye, wet in the other? Well, that's my next one. You stole my thunder. Okay, wait, how many of you have both? Could you raise your hand one more time? Okay. And how many have no idea? Okay. Well, the good news is you're all in the right place again, but that gives us a sense of kind of the areas that we want to cover. So you saw the video, or you heard, 15 million Americans currently have some stage of macular degeneration. Expected to be 20 by 2020. So that's not going in the right direction, wouldn't you agree? Okay, that's what we're here for. We want to make sure it never gets to 20. Okay? A couple tidbits. You have packets that you all got at registration, and inside those packets is a notepad and a pen, so you can take notes, or we encourage it, but don't feel like you have to write copious notes, because a lot of the information is in the packet. But that also, if you have a question for a presenter that you think of during their presentation, you can jot yourself a little reminder. So when we get to the Q&A part, okay? So those numbers don't surprise me, and they won't surprise Dr. Brilliant either, because in terms of the numbers of you that raised your hands, is because 80 to 85, 90% of people have dry. It's really 10 to 15% have wet, okay? So this room represents that correlation. Now you may say, well, just because I have dry, am I going to get wet? Dr. Brilliant will talk about this, but the answer is no, okay? And it is true, and we know this more and more, that the earlier we catch it, the earlier your ophthalmologist catches it, or I say ophthalmologist, catches it, the better. It's just like everything else in healthcare. The earlier it's detected, the better. And I can tell you that the professionals and the physicians and the docs out there, we are getting more and more tools, and I'll talk about this in the research part of the program, but there's more and more out there for them to detect it earlier. But you have to go see your eye doctor, your ophthalmologist, okay? You have to. Otherwise, they're not going to catch it early. And Dr. Brilliant may disagree with this because there's a little bit of controversy, and I'm not an MD, but I always say I know enough to be dangerous. In a way, it's better that if a family member, mother or a parent, has macular degeneration, a lot of research shows that you're 3 times more likely to have it. There is a genetic component to it that is serious. So I always encourage, if the biggest gift you can give your kids besides your love is to make sure that they're going to an ophthalmologist beginning in their 40s, but definitely by age 50. Because macular degeneration is being detected at age 50. So we're all living longer, so some people could live with it for half their life. That's a big deal. So make sure you're on your kids. You know, you were telling them all their life what to do, or at least part of it, right? So it shouldn't be difficult for you to tell them this. It's the best thing you can do for them. Okay? So you're going to get a lot of information tonight. Some of it you may already know, and it's going to reinforce what you know or what you've been told by your doctor or your retina doc, you know, an occupational therapist or a low vision specialist. So it may sound familiar. It's going to maybe reinforce that. But then hopefully there's a lot of information that you didn't know, and you know, you'll be hearing more about that. The last thing I'm going to say before, and Dr. Brilliant, we're going to bring you up here, I'm going to introduce you, is that, well, I'm just going to plug this. You're close to Philadelphia. We are lucky to, and we take these programs all over the country, by the way. All of you are so close to the city, you know, a center of ophthalmology with Will's Eye and Shea and all that. And so one of our commitments to this patient education program is to encourage all of you to get involved in a clinical trial. If you can, ask your retina doc. And you know, they get irritated at me, but I'm just gonna say this. They don't have time to tell you everything. That's with the gap that we can fill, okay? And Alvina knows that. She's a personal testimony to that. They don't have a lot of time to give you all this information. And you can get your grandkids or your kids to get online for you, and we'll hope you'll go on our website, but you need to have trusted, credible information. There's a lot of stuff out there that's not really that true or not that credible, okay? But you have to ask your doctor questions. Write down 3 or 4 questions before you go get that Lucentis shot. And ask them. Some people don't even know if they're getting a Lucentis or Eylea or Avastin, right? You should know what they're injecting in your eye. And if you're not sure what questions to ask, we can help you with that. But always go prepared with 3 questions and make them answer them. And make them give you that time. Okay, they hate it when I say that, but it's important because you can, the more you know, the better. Okay, and especially with this disease. All right, so that's my pulpit for us. I'll be back with more of that, but let's bring Dr. Brilliant up. You want to mosey up here? Dr. Brilliant, as I said, we've been working with, well, we've had the privilege of working with Dr. Richard Brilliant for a couple years now, 3 or 4 or 5, maybe even. Dr. Brilliant is an OD and a diplomate, which is a distinction given to low vision experts by the American Academy of Optometry. He's an optometrist who's recognized as one of the world's finest low vision specialists. He's an avid innovator. He has designed and developed hundreds of the best low vision devices. This guy knows what he's talking about, people. For more than 30 years, you hate it when I say that, don't you? Dr. Brilliant's been involved in clinical investigations for low vision manufacturers. In addition to lecturing throughout the world, he published countless articles and authored a popular optometry textbook. He's the only optometrist on the board of the FDA. That is huge, because things like you're going to hear from an expert later, these things need to be approved by the FDA, and he's the only optometrist on their board. I'm just going to say that in his spare time, he teaches at Salus University, so he pays forward. And is really, I have personally witnessed that he's sharing his wisdom and knowledge and breadth and depth of experience with the younger generation who are going to school to become a Dr. Brilliant. And to me, that is the ultimate. Besides taking care of patients like all of you and providing high quality, compassionate patient care, he's also mentoring and bringing up the next generation to carry that forward. So without further ado, let's bring him up. Give him a round of applause. Thanks.
Thank you very much. Thank you. I think that was sort of too much, but I appreciate it. Thank you. And yes, my name is Dr. Brilliant, and my first name is Richard, so I'm rich and I'm brilliant. But I just wish one of them was true, that's all. Mostly the rich, but. All right, I've been asked to talk about macular degeneration, and could everybody hear me? Yeah, okay. I'm going to look at the board here because this is a presentation I'd given a while ago, and I'm not familiar with it right now, but I will be as I go on. So just to let you know, macular degeneration is caused, well, there's a lot of different types of macular degeneration. The one that you hear most about, obviously, is age-related macular degeneration, which gets the most press, which is the most common, and I guess affects the most people. But I've just listed here 2 other types that are fairly common. Stargardt's, which affects those individuals who are in the late teenage years. So these individuals probably about 16, 17 years old, are reporting reduced vision. They go to their eye doctor. The eye doctor looks inside the eye and sees nothing. Everything looks good. But the patient is reporting, I'm not seeing as clearly. Most of the time, the doctor will tell the patient it's probably due to the stress in school, and just go and relax. You don't really need a pair of glasses that will help at this point. And we'll check you in a couple of months. Little do they know that there's things going on inside the retina that's causing this type of damage. And so they get a form of macular degeneration similar to age-related when they're in their late teens, early 20s. Their condition gets worse as time goes on, a lot worse than age-related macular degeneration, unfortunately. So these individuals have it for a much longer period of time, and generally their acuity is generally worse over a period of time. There's also a condition that we commonly see as Best's disease, and this affects much younger children. So even young children in their elementary school will start coming down with macular degeneration. So any form of macular degeneration obviously affects the macular area and causes a reduction in visual acuity. Macular is responsible for detail vision, 20/20 vision, and color vision. So as the macular degeneration progresses, no matter what form you have, your color vision is also going to be affected. Your contrast sensitivity is going to be affected, and we'll talk about that in a few minutes. So the macular area is responsible for a lot of things. Are you familiar with the way the retina operates for the most part? There's the macular area, no? Well, for the most part, there's basically two different types of cells that form the retina. The cones, which are responsible for detail vision, color vision, which is found very heavily in the macular area, and then the rods, which are responsible for motion and nighttime vision. The rods are found in the periphery of the retina. So as you go from the periphery of the retina toward the macula, you get less and less rods and more cones. So it's really the cones that are being damaged in macular degeneration. The rods remain the same for the most part. So those individuals with macular degeneration, I'm sure most of you have been told by your eye doctor, you do have this condition, but don't worry because you're not going to go totally blind. And that's because it generally does not affect the rods, and therefore you have always peripheral vision. Peripheral vision allows you to walk around without bumping into things. It allows you to see motion. It allows you to see nighttime vision for the most part, all right? But as the condition progresses, the macula becomes worse, and therefore your visual acuity gets reduced, okay? Actually, within the macula, there's a foveola, and then there's a fovea, and then there's the macula. So it really is affecting the foveola, the fovea, and then the macula, but we call it macular degeneration. All right, what I tried to do here is basically just show you, for those that could see the slide presentation, what we think patients with macular degeneration experience. They might be looking at something, for instance, looking at somebody's face, and they see the head is there, they see the body, but they don't see the detail of the face. So a nose might be missing, they're not seeing the eyes itself, but they're able to see the face for the most part. Okay, so the detail gets worse as the condition progresses. What are the risk factors? We certainly know with age-related macular degeneration, one of the major risk factors is age. Unfortunately, as we get older, there's a greater chance of getting age-related macular degeneration. Generally, age-related macular degeneration starts at about 45, 50 years old, and then progresses. It's not something that happens immediately. Most patients think that something happened and all of a sudden they woke up one morning and they have this condition. It's a condition that's occurred for a period of time, and you don't really notice it until all of a sudden you get that reduction in vision. And a lot of times it affects only one eye in the beginning, and it's asymmetrical, And therefore, when you're using both eyes, you might not even notice the fact that you're not seeing out of one eye that well. Okay? So it's a very slow process for the most part. It does progress to a certain point, and as we said in the beginning, supposedly in most cases it'll stop at a certain point because it doesn't affect the rods per se, or the peripheral retina. Okay? So we do know age is a factor. We do know exposure to the sunlight. UVA and UVB are responsible for hastening this condition. So if you do get a pair of sunglasses, which I encourage you to do anytime you're outside, you got to make sure you get a pair of sunglasses that say 100% protection from UVA and UVB. And I hope eye doctors are not upset by this, but if you don't really need a prescription pair of glasses, you could just go to the store and buy a pair. As long as it says 100% UVA, UVB protection, you'll get the same result as a prescription pair of glasses for the most part. Okay? We do know race is a factor as well. It affects white population more than the black population. Probably because the black population has more pigment. And we do know that pigment protects the eye a little bit more so from the ultraviolet light. But we do know, when we look at the statistics, that the white population is affected greater than the black population. People with blue eyes. And again, that makes sense because blue eyes, they don't have as much pigment, and therefore the ultraviolet light is able to be transmitted back to the retina and affects the cells of the retina. Smoking. Anybody who's smoking at this point, you should stop. I know it's easier said than done. I mean, if you look at me, they say I should stop eating, and obviously that hasn't happened. But we do know smoking increases the chance of getting macular degeneration by 50%. And it also hastens the condition. So if you're smoking and you have macular degeneration, it's going to hasten the condition of your macular degeneration. As Dawn had said, family history of macular degeneration is somewhat common as well. We don't know what the statistics are there, but we do know if somebody in the family has it, you certainly stand a greater chance of getting it also. But there's so many different factors that we're still not sure of what actually causes macular degeneration. And I can tell you, over the years, I've seen twins, and one has it and one doesn't. So I still don't understand all the dynamics that go along with macular degeneration. And I think most doctors don't, otherwise we'd have it cured by now. But I think they're getting there, so that's the good news. This is probably a little less. People who are farsighted in one study seem to show a greater chance of getting macular degeneration. But again, if you're farsighted, don't worry about it. Well, again, unfortunately, you can't worry about any of this because if you have it, you have it. If you're going to get it, you're going to get it. And hopefully there will be a day when it'll be cured. But those individuals who are farsighted, one study says it's a greater chance, as well as a thing called the cup-to-disc ratio. And this is something when the doctor looks inside the eye, the optic nerve has a cup. And as that cup gets larger, it appears that there's less chance of getting macular degeneration. And I think the thinking here is when a cup-to-disc ratio gets larger, generally it's because the pressure inside the eye is greater. And therefore, that seems to prevent macular degeneration. Unfortunately, when the pressure gets higher, that causes glaucoma. So I'm not so sure which one is better, but if the cup-to-disc ratio is larger than normal, you think about glaucoma, but you think less about macular degeneration. Also, those individuals who have high blood pressure, high cholesterol, diabetes, stand a greater chance of getting macular degeneration. And again, that makes sense in the fact that we think with age-related macular degeneration, there's a lack of oxygen and nourishment to the macular area, and therefore these diseases or disorders sort of prevent that type of situation where you're going to get more oxygen and more food with those disease processes. Diet and obesity, again, is another factor for those individuals with age-related macular degeneration. We do know, or we think we know, that green leafy vegetables, yellow vegetables, orange vegetables are healthier for those individuals. But if you're overweight, those are absorbed by the adipose tissue, the fatty tissue, and therefore less gets into the macular area. So the obesity prevents the nourishment to the macular area by absorbing a lot of those leafy green vegetables. We do know, again, those individuals who tend to eat fish more than meat do better and less chance of age-related macular degeneration. The thinking is fish should probably be eaten at least 2 or 3 times a week. Again, I think if you're more prone to getting macular degeneration, you could eat fish every day, and unfortunately, you're still going to have the condition. But we do know fish is less of a factor than eating meat. If you eat red meat, much greater chance of getting macular degeneration. What are the signs and symptoms of age-related macular degeneration? And we do know there's the 2 types that when we talk about. There's the wet type, which is exudative macular degeneration, and the dry type, which is atrophic age-related macular degeneration. As Dawn had mentioned, the dry type is about 90% of the population. The wet type is only about 10%. But the wet type is the one that you can treat with injections. The dry type, really, there is nothing other than vitamins, which we'll talk about in a few minutes. But the signs and symptoms of both age-related wet and dry macular degeneration are pretty much the same. Over a period of time, you get reduced visual acuity, again, because it affects the cones in the macula, and your visual acuity is affected, as well as I said, the color vision. And that affects you at all distances, distance, intermediate, and near. You generally get a central field loss. You get this blind spot. In medical terms, it's called a scotoma. So if any doctor has ever mentioned to you that you have a scotoma, all it is a blind spot, and that's associated with the fact that the cells in the macular area are not functioning, and therefore you develop this blind spot. There's also a condition called metamorphopsia, and that's where you get distortion in the macular area. So some patients will report that things look distorted. Okay? Generally, that's associated with edema or swelling of the macular area. And it causes this metamorphopsia. A lot of you have been asked by your doctor to use a grid. How many people use a grid? Oh, it's in the packet. Yeah. If you look at that grid, sometimes the grid, parts of that grid will be missing. That's the scotoma. Or the lines itself might be distorted. That's metamorphopsia. You're going to get fluctuating vision. There are going to be days that you wake up and your vision's not too bad. And then over a period of time, it gets worse. Then again, it gets better that day. It goes back and forth, back and forth. So that's not unusual. Most patients will report this fluctuation in vision. Most patients are disturbed by that, and they think their vision is getting worse, when in reality it's not. That's just how the condition works for the most part. Okay. If it's constant, then obviously that's a concern. But fluctuation in vision, not so much a concern, or as much a concern as the constant. You're going to get reduced contrast. What does that mean? The thing that I find fascinating with most patients with macular degeneration, they'll report the fact that they're not seeing as well. They'll go to their retinal doctor. The retinal doctor will take a visual acuity and tell you your vision is the same. You're just worried about it. You're thinking about it too much. It's the same. You go to your other doctor, your primary care eye doctor. Primary care doctor will take visual acuity again and report your vision is the same. It's not bad. It's not getting worse. But you know it's worse. The reason you're noticing this, and the reason the doctor says this, is the fact that when they take a visual acuity, The visual acuity that you're looking at, the letter or the number that you're looking at, has the greatest contrast. It's the blackest print on the whitest background. That's 100% contrast. The world doesn't exist that way. So as you get older, as the condition progresses, your contrast decreases. Okay? So what does that really mean? And this is what I ask the patient. When the patient says, well, I know it's not as good as it was before. And I'll say, well, when we look at the chart looks exactly, it's giving you the same response that you had when we saw you 6 months ago. Contrast in the real world, they'll report that the curb sort of blends in with the street. They'll report that when we go up and down steps, it's hard to tell the depth of the step or how many steps there are. That's the most common complaints with a reduction in your contrast. You're looking at a picture on the TV, it's all washed out. It's contrast. The detail is not there, okay? The problem is most doctors don't check contrast sensitivity. And if you did, you would notice that there was a decrease, and therefore what you're reporting to the doctor is true, but the doctor is not using the proper chart to evaluate you. But if you talk to the doctor's going to tell you, well, we do know contrast decreases as we get older, regardless of whether you have macular degeneration or not. But if you have macular degeneration, it's going to get worse faster. But what do we do about it? For years, we felt there's nothing we could do about enhancing contrast. We know now that you can. There are basically 3 things that we could do to enhance contrast. We could put more light. When you put more light on something, it improves the contrast. You could put filters in front of your eyes, which will improve contrast. And a filter, you could also put a piece of tape, a fluorescent tape on a step or a curb, and that makes it easier to see. That's filter, that's contrast, improved contrast. Or you could provide magnification. If you provide magnification, improve illumination, and add some type of filter for contrast, those are the 3 things that we could do to improve your vision as well as your contrast sensitivity, okay? And that's pretty much what's done with a low vision evaluation. So when your doctor says for you to go for a low vision evaluation, that's what's looked at during that evaluation. You get a reduced depth perception as well as reduction in your binocular vision. And it's generally because one eye progresses quicker than the other. And it's not unusual for one eye to be bad, the other eye good, and then over a period of time, the one that was bad is actually better than the one that was good, which now becomes worse. So it's not unusual for it to go back and forth like that, okay? But when you don't have 2 eyes working together, when they both don't have the same visual acuity, you're going to have a reduction in your depth perception or your binocular vision, and that's very, very common. So what does that mean? Again, when you get near steps or a curb, you don't really know the depth of that step or curb. You're going to get reduced color vision. Generally, it affects those individuals where you get a reduction in your red-green color vision. Okay, and that's associated again with the cones being affected in the macular area. You're going to need increased illumination, direct illumination, okay? The thing that probably is most important, and I hear this all the time with my patients, is the fact that, well, I did hear you. You told me that I need more light. And so what my husband did, I'm talking to the wife, my husband took the lights out of the ceiling, and what it was a 100-watt bulb, and now he put in a 200-watt bulb. All right, well, you're getting a little bit more light, but you're also using twice the amount of energy, and if you keep it on long enough, you're going to get a sunburn probably from that light. So the secret to illumination is not necessarily increasing the wattage of the bulb, but moving the light source closer to what you're looking at. If you ever have a light source that has like a lamp that you could move the arm of the lamp, you have one. If you bring it closer to what you're reading or looking at, even in the kitchen, you'll see you get a lot more light than changing the light bulb. I'm running out of time already? Okay. You can be bothered by glare and photophobia, bothered by the sun. Why is that? Most doctors don't know. It's never written in the literature. I think, and I'm pretty sure I'm right, I think what happens is when the cells on the retina are not functioning properly, when light comes in and goes onto the retina, instead of being absorbed by the cells, it's deflected. And therefore you get this glaring effect on the retina, and you're bothered more so by glare and by sunlight. And that's why you tend to be bothered more so than the average person. Also, those individuals with age-related macular degeneration might have this condition called Charles-Bonnet syndrome, where they might report that they're seeing things that aren't there. They see, this is common, it's pink elephants, or they see somebody's face that they're familiar with, and they see it whether their eyes are open or their eyes are closed. And they constantly see this. They know there's nobody in the room, but they're seeing these individuals or faces. It's Charles-Bonnet syndrome. At one time, we heard this, we would send the patient to a psychiatrist thinking you're hallucinating. But in reality, we know it's the brain causing tricks, making the person think there's something there. We do know the eyes don't really see. It's the brain that sees. The eye sends information back to the brain. It's the brain that's seeing. So when the brain is confused a little bit, it might appear that there's something in the room, and therefore it's this Charles-Bonnet syndrome. We do know those individuals who tend to live by themselves have a greater chance of getting Charles-Bonnet syndrome. If they don't associate with a lot of individuals, greater chance of getting this Charles-Bonnet syndrome. If any one of you have it, generally, just like it came, it'll go after a year or two. They've tried a whole bunch of different medications and everything else, doesn't seem to work. We do know that if you socialize a little bit more, if you do use low vision devices, which enhances your vision, then the chance of eliminating that condition occurs quicker. For those who could see, I just wanted to show you some pictures of what we see when we look at age-related macular degeneration. And this is, obviously there's a lot of disorders in the eye, a lot of disease processes. But this is one condition where it looks different for a lot of patients. It's not characteristic. There's not the same appearance for every patient with age-related macular degeneration. This is the optic nerve. This is the cup that I was telling you about, the cup-to-disc ratio. This is the macula area. If you notice, the blood vessels go around the macula. You never want blood vessels to cross over the macula, because it's like looking through a window where there's tree branches. It affects your vision. So you don't ever want blood vessels to grow over the macula area. When that occurs, that's a form of wet macular degeneration. That's why you get an injection to eliminate those blood vessels that grow over the macula area. Again, for those who could see this, just various forms of macular degeneration. And one of the characteristic appearances of macular degeneration are things called drusens. If you've talked to your doctor might have told you that you have drusens. With age-related macular degeneration, there's basically two different types of drusens, hard drusens and soft drusens. And again, just slightly different appearance of the two, okay? What are drusens? The cells have to get rid of some of their garbage. And sometimes when they can't get rid of it totally, it forms these sort of vesicles, and those are drusens. So drusens are just garbage collectors, okay? And so we do know they're associated with macular degeneration. Just wanted to show you, too, how it becomes a little difficult. I told you about Stargardt's before. This is characteristic drusens. These are not drusens. They are what they call Pisces, and they're associated with Stargardt's. So if you look very carefully, you can see the difference between the two, okay? Visual acuity-wise, individuals with age-related macular degeneration, if you have the dry type, could vary anywhere from 20/20 to about 20/400. What does that mean? That means if something is 400 feet away, I could see that, but you have to get to 20 feet to see the same thing. So this is the distance, the top number. The bottom number is the size of the target. Okay, and that's how visual acuity is recorded. The wet type obviously will get worse over a period of time. Although now with injections, the injections do slow the process down. I know one of the things that most patients complain about is the fact that they were never told when they get these injections that the vision is not going to improve dramatically. Generally, the injections are there just to slow the process down to go from wet macular degeneration back to dry. Okay? In some cases, patients will report a slight increase in visual acuity because they caught it earlier in time and they were able to reverse the situation a little bit more than those who have had the wet type for a longer period of time. But wet macular degeneration, when you get the injection is not meant to cure, it's meant to slow the process down and to convert it back to dry type. All right, we talked about how do you manage this, and I'll be done in 2 more minutes, 1 minute. To help those individuals with the dry type, it's recommended that you take the ARID multivitamin, and it's the ARIDS 2 now that appears to be the better of the two. The ARIDS 1 was original, ARIDS 2 now. The ARIDS 1 had vitamin A, which we do know if you smoke and you take vitamin A, there's a greater chance of getting lung cancer. So the ARIDS 1 has been, vitamin A has been eliminated. In both cases, they have vitamin E, and I know at one time vitamin E was considered the end-all of everything. If you took vitamin E, it solved all your problems. You know, your sex life was better, everything was better with vitamin E. We do know now that if you have a heart condition, you can only take 400 units of vitamin E. So if you're taking the ARIDS, whether it be 1 or 2, and you're taking a multivitamin, and you do have a heart problem, you should talk to your doctor about that before you're continuing to take it. If you don't have a heart condition, you could take both, not a problem, okay? The wet type, we know, you get either laser, which is sort of passé now. There are sometimes laser is important to use, but we do know that every time you use the laser, you're burning tissue, and therefore you're creating blind spots or scotomas, as well as trying to prevent the bleeding, fluid uptake, or blood vessel growth. So now the injections are working pretty well. And the medication that's actually injected into your eye is actually a cancer drug. So it actually is preventing blood vessel growth. All right, I think that's, okay.
So, thank you.
You're welcome.
Good stuff. See, I gave him 2 minutes, didn't I? I said 1, I gave him 2, right? So we're going to keep Dr. Brilliant up here for a few minutes to get questions that you might have thought of while he was speaking or want to ask. So put your hand up high, and Maggie or Lynn will come around and get the mic in front of you.
What's the difference between the ARED 2 and those eye caps? They have a new chewable one now.
Yeah, very little difference. The ARIDS 2, the PreserVision, and the eye caps are pretty much the same. You could look, you'll see that it has the same amount, the same percentage of vitamins in each. So you could take either one, which I think the eye caps are a little cheaper.
Okay, got this. We want to leave as much time as we can. We've got a couple hands up.
You spoke about the hard and soft tissues. Drusen? Yeah, drusen rather. And what is the difference? Is one worse than the other?
There you go. You can stay closer.
Okay. No, drusens are drusens. They have the same effect, unfortunately. There's just 2 different varieties of the drusens. They might be associated with different types of macular degeneration, but they're still associated with, more so with macular degeneration. Now, the other thing, too, is you can have drusens and not have macular degeneration. So sometimes, and I know I shouldn't tell you this, but I've never been examined. I've never had an eye exam, which is stupid. So when I was a student, and this was 40 years ago, we would examine each other, and that was the only time I had an eye exam was my fellow, student. And I think they did report that I had drusens at that time. So I'm hoping as the type that I don't have macular degeneration.
Okay.
I don't know why I haven't asked this question of my wife's doctor before. With wet macular degeneration, should you be concerned about antiplatelet medication or anticoagulants? Wouldn't that make the hemorrhage worse?
Yeah. I don't think there's any scientific proof at this point. When they're getting the injections, it's not as if you have a bleed, it's a fluid leak. The blood vessels become more brittle, and so it's like diabetes, you get a leak of the fluid. So it doesn't necessarily have to be blood. So, again, yeah, I mean, it definitely, yeah.
You put that on your list of 3 questions.
You can there are hemorrhages associated with macular degeneration as well, but it doesn't necessarily mean if you're getting an injection that's associated with that. It could be blood vessel growth, it could be just fluid or hemorrhage.
One more, a couple more. Lynn, we are over. I'm sorry, I didn't see you.
What part does lutein, is it good or bad, or?
It's a good question.
Yeah, the question is what part does lutein play? We do know that as the eye gets older, with macular degeneration, there's a shortage of lutein and xanthine. But we also know with the ARIDS-2 study, where they introduced fish oil, lutein, and xanthine, they found the fish oil did nothing. They found the lutein and the xanthine did nothing. But they feel that it's safer to use than vitamin A, and because there is a shortage, it doesn't hurt to take this lutein and xanthine. So we do know we get that in green vegetables. But again, I think you'd have to be like Popeye, to be eating cans of spinach every day. So if you just have some green leafy vegetables every day, a little bit, it's not going to really do a lot, but it might help. It's not going to hurt. But that's the same concept with lutein and xanthine. So that is in the ARIDS-2 study.
So one of the things we know, just to comment on that, and to piggyback off of Dr. Brilliant, is sometimes we have a nutritionist come to our sessions. Next time we'll bring one. But you're born with a certain amount of lutein, and that's it. And so the only, as Dr. Brilliant said, as that kind of lutein gets used up as you age, and your retina needs lutein, correct? Your macula needs that. It thrives on that. So there's a handout in your packet that has a shopping list of all the ingredients, fruits, vegetables, things that we know, that experts say and we know are really good for you to purchase and eat on a regular basis. Your diet is very important. Now, some of you like spinach. They might be eating it 3 times a day, but those things really do make a difference, especially with dry, but can't hurt you with wet, because eye healthy is heart healthy in terms of diet. So it's going to improve your overall well-being regardless, right, Doc?
Yeah.
Okay.
Are there any products on the market like the drops that you hear about and supplements? Because we get tons of mail about that.
You mean for the dry, like vitamins?
I have wet, and I want to know if there's anything that I could take that would be helpful.
As a supplement.
Yeah, I mean, it doesn't hurt to take the ARIDS-2, but in research, there are things they're talking about now about drops and pills and things like that, but it has not been FDA approved. It has not been researched enough at this point to say there's something out there for sure that's worth taking. So anytime you might get information on that, I'd take it with a grain of salt at this point, okay? Those things should be FDA approved, obviously, if you're going to take it with the idea that's going to help you. And ARIDS-2 was.
Well, that that goes, let me just finish that thought, hang on. That goes back to what I said in the very beginning. There's a lot of information out there and a lot of things, but I always tell people, if you call us or you contact us and we don't know about it, or we don't, have something to say about it, chances are it's maybe not a great idea, because you need a trusted resource to help you make those decisions, because we know you want to do whatever you can to help you see better. We know that, and people out there in the big old world know that too. So I always tell people, if we don't know about it, then chances are it's, if we did know about it, we'd be telling everybody if it worked.
You'd probably hear it on the news and TV that something like that came out before you even spoke to your doctors, for the most part. But my wife constantly tells me that there's pills out there to make you think better, and it doesn't exist at this point. I mean, they're selling these things.
All right, we have time for 3 more.
Recently, I've seen devices that allow colorblind people to see color. Are there devices like that for the contrast issue, things like the curb in the street and the steps and that?
Yeah, there are filters that the doctor could play around with to come up with that. If you're colorblind, they found that a red lens in front of one eye will enhance. They don't get color vision, it just gets enhancement. So they could tell the difference now between red and green, whereas before it all looked the same.
Let me just add to that. And also, don't forget, we have our friends at VFO that have a lot of tools and devices out on the table out there to help with low vision and contrast and that kind of thing. Mike Parker and Bill are in the back. Again, this isn't twisting your arm to buy anything. That's not why they're here. We just bring them to you so that you can demonstrate and touch and feel and look at them, because these aren't things that you're going to buy at Walmart or Costco. So, these folks have those, so we encourage you to visit them at the end. 2 more, Lynn, we good?
How important is the lithium in the eye vitamins? I noticed that some have certain amounts in and some don't.
Lutein,
Well, it says lithium.
I'm not familiar with lithium as being. I'm not familiar with lithium as being involved. Lutein. Lutein. Yes, again, I'm sorry.
Some have less amounts than others. Does it matter?
Oh, no, because again, they have not proved that lutein is absorbed into the eye when you take it. But again, the thinking is you should take it because we do know there's a reduction, and we don't know of any other way of getting it into the eye at this point. So I think it's 10%, 10 units of lutein is recommended, but you could take a lot more than that if it's not going to hurt you.
Thank you.
But let me ask the thing on color vision. There's actually an instrument that you could point to something and it'll tell you the exact color of that, and it's fairly inexpensive.
I was more concerned with the contrast issue rather than.
Yeah.
Can I also, folks, Dr. Brilliant's going to be here at the end. So if we don't get to your question, we'll put him in the corner and he's going to answer every question you have, okay? So we only have time for one more because we need to move forward.
Okay. I was told that in your 90s, the eye vitamins will not help.
In your 90s.
Right.
Age 90?
It's not going to hurt. When you get to 90, that the vitamins are not going to help. I think if you're taking them, you should continue to take them. Doesn't matter your age. The thing it's not to burst your bubble, but we do know the AREDS 2 or the eye caps doesn't work on every patient. We recommend it because we don't know anything better, and we don't know which patients are going to benefit from it and which patients don't. But we do know for a fact, which a doctor's never going to tell you, and I shouldn't be saying this, but that it doesn't work for every single patient. So you might take it and it has no effect. Somebody else might take it and swear by it. But if you're taking it, I think it does. If you can't afford it, it's one thing, but you should continue to take it.
Okay, good. Well, we'll get your question answered by the doctor one-on-one, okay? So don't forget it, all right? Give the doctor another round here. Good questions. Great questions. And he's going to be here, so we'll make sure you get time with him, okay? Also, if you're 90 and anybody, this is what I say, if you're 90 and anybody tells you something's not going to help or you can't do it, you tell them they're full of pahooey. You can do whatever you want at 90. That's right. Okay, can we have our next expert panelist, Dr. Brilliant? Maybe you can talk to later after this. Thank you. I know, I'm tough, aren't I? Okay. Next on deck, we're thrilled to have Allison Schoenfeld with us. Allison is a registered occupational therapist. And Allison's going to talk to us about a new tool, fairly new tool out there that some of you may be interested in. Allison graduated from Medical College of Virginia, again with a degree in occupational therapy. Her career led her to a path in acute inpatient rehabilitation, where she specialized in brain injury. As you heard Dr. Brilliant say, you don't see with your eyes, you see with your brain, because your retina is attached to your optic nerve, which is attached to your brain. So if anybody tells you you see with your eyes, you can go out there and tell them, no, you don't, you see with your brain. Okay, so Allison knows a lot about the brain. While on the brain injury unit, she began her treatments focusing on patients with both neurological and low vision conditions. And that paved her path to specialize in low vision occupational therapy. She's rare. People like Allison, professionals like Allison are rare out there, but at MVRF, we are huge advocates, and I think Dr. Brilliant shares our passion for this, about getting more and more people into this field. After several years of working in hospitals, she left Mount Sinai in New York, and she began a low vision occupational therapy program with SUNY College of Optometry, the first of its kind. So like I said, this is pioneering stuff. You're going to see more and more of it out there. She began a private practice in Brooklyn, and that's where she came from today, all the way from Brooklyn, focusing on treating patients with low vision and vestibular disorders. And then last year, she became a consultant with Vision Care after successfully bringing the implantable miniature telescope to her patients in Brooklyn. So she's going to talk to you a little bit tonight about that, educate you a little bit on what that implant, that little telescope does, what it is, and how many of you have heard about it before? Okay, we've got a few. Well, you're going to learn more, and we're going to bring Allison up. Come on up, Allison.
They don't get bigger. Oh. All right. It's a good thing they got bigger, because then you really would need my services. So, thank you for having me, and thanks for coming. And yes. And I'm very glad the weather is better tonight than it was yesterday, because I'm sure it would have been tough getting here. So, as you've heard, I have kind of married my background with a little bit of neurology, a little bit of vision, and I am here to present kind of a combination of occupational therapy and the use of the implantable mini telescope. So there were a few hands who heard about the implantable telescope, so hopefully after tonight's talk, you'll have a better understanding of it. But also, I brought a simulator here with me, which kind of simulates what we use with our patients who may be candidates, to give it a try and just kind of see what the device is about. So let's see how Sorry about that. Okay, so this is the implantable telescope. It is the only FDA-approved device that is out there, and it's used for age-related macular degeneration. The SupportSight treatment program is designed to help end-stage AMD patients understand how to be a candidate, receive consultation for the device, undergo the telescope implant procedure, and follow an individualized visual rehab program to work towards achieving their desired goals, which we'll talk a little bit about later on. So it is approved by Medicare and other Medicare plans, as well as it is endorsed by the AMA, and it's been given what, I don't know if you guys understand what a CPT code is or if you've ever heard that, but it is a code that is used by the AMA that actually validates the device. So there's a growing patient awareness. I know there was a small amount of hands as to how many people have heard about the IMT. So those in the audience who have heard about it, how did you hear about it?
Just read about it in the booklet.
Okay, so a little literature, and I think there was another hand. Was there another one? Yeah.
I saw something on TV, like a documentary.
Okay, yes. Anybody else? Okay, so the IMT is gaining some popularity. It's starting to become a standard of treatment if you are a candidate for low vision rehab. And there has been some literature, some TV shows, and some other, like Emory Eye Center, are trying to advocate and use the device, and so we're starting to get a lot of patient awareness. Whoops. Okay. So SupportSight has teams all across the country. So right now, there are over 100 centers across the country that are using the implantable telescope. So some of these centers are within private practices. Dr. Brilliant, I'm not sure how you're practicing, if you're with a university or a private practice? Both. So I'm a private practice, and we're using it within my practice as well as multiple or many universities or medical centers out there. These teams that are out there, and they're all across the country, and I know many of you, some of you may have come from the tri-state area, but whether you're in New York, New Jersey, Pennsylvania, there are centers all across the country that are out there that are utilizing this technology.
We have the list.
Okay, there is a list if you are interested. So these teams are currently completing evaluations, performing the surgeries for persons who meet the certain criteria, which we'll talk about a little bit later, for age, visual, and medical criteria. So, how can we help this population with the implantable telescope? Well, we can help in all aspects. Before we talk about the device and how it could help people with end-stage macular degeneration, let's first look at how the disease affects a person's ability to carry out their self-care tasks or their ADLs. Someone with end-stage AMD has not only one impacted eye, but usually both, as Dr. Brilliant had talked about. So they have bilateral central scotomas, and that's the word that I don't know how many are familiar, but that blind spot in the center of the eye that is characteristic of macular degeneration. And this can affect so many different areas of life. For example, these scotomas can impact facial recognition. So when someone is approaching, they can't recognize who the person is. And many of my patients have said to me that they fear social situations because if they can't recognize somebody, because the scotoma or the blind spot is in the center of somebody's face and they can't see the detail, then another person may think that this person is being rude, or maybe they're losing a little something, and that actually makes them feel a little self-conscious, and they'll try to avoid social situations. It could also restrict the ability to communicate with others, as they may have difficulty looking at their computer, using their telephone, or even just picking up on the subtleties of body language. Quality of life is about all of these, and so AMD impacts quality of life to a very, very high degree. In fact, depression is a very common complication with AMD. So if you can see the screen, so let's just say that this is the blind spot or the scotoma. So that blind spot is your central vision, as Dr. Brilliant had talked about. And even though you still have your peripheral vision, you're missing the middle of a newspaper, or if you're in a supermarket, you're missing things in the aisle that you need to look at. And then the last picture is, in a social situation, is not being able to see the details of somebody's face. So you can see how that can very much interfere with somebody's desire to want to be social and why somebody can be depressed. So let's talk about the technology side of the IMT, or the implantable telescope. So this implantable telescope gives you 2.7 to 3x magnification. And one eye is selected. And we'll talk a little bit about the process of how the eye is selected by your medical team. So the eye that is implanted is called the implant eye. And the other eye that is not implanted, so the telescope eye that's implanted, you're going to use for your detail, whether that is distance, intermediate, or near vision. The fellow eye, the non-implant eye, is going to be used for mobility. So that is the eye that is going to help you navigate the streets, a supermarket. So there's a distinction. One eye is for the telescope, the other eye is for mobility. The implant is pretty small. It's actually the size of a pea. So if you think how small that is. And it's very similar to the lens that they put in after cataract surgery. So it's very small, and it goes right into the eye, which will provide you with the amount of magnification. And that is usually coupled with different pairs of glasses depending on the task. So we talked about that for the telescope, it's used for near, intermediate, and distance. So you're gonna have, anybody who undergoes the implant will have 3 different pair of glasses to help maximize how that initial 3x magnification is going to work. It sits inside the eye, and it actually moves with the eye. So if I look to the right, the telescope looks to the right. If I look up or I look down, the telescope is going to move with the eye. So it's accessible with any movement. The difference between a handheld telescope that you would hold up for spotting, does anybody use handheld telescopes for spotting faces or signage or sporting events? Anybody have one? You have one. So you know when you use it, you kind of have to steady it against your nose, you have to hold it up, you have to find the target, but you really have to move the telescope with your head position, and the IMT actually moves just like your eye. So, how it works. If you can see the slide that is in front of you, the picture on the left, the patient may be able to see that there are letters. So, if you may not be able to see, but here's the lens, and here's the light coming in, and this is the retina. And this is how what you're seeing is projected on the retina. And the word is cat. But here is that scotoma. Here's that blind spot. But the words, or whatever the image is centered within the blind spot, so we know that you're not going to be able to see the detail. With the telescope, what happens is, as Dr. Brilliant talked about, one of the principles of low vision rehab is working with magnification. And the idea of magnification is we're not changing the blind spot. That blind spot is still there. But what we're doing is we're magnifying the image that when it is projecting to the back of the retina, it is much larger than the scotoma. Therefore, you're able to see much more detail of whatever you're looking at. Does that make sense? Okay, great. The new vision in the telescope implant eye can be used for viewing distances, distance, intermediate, and near. And as we talked about, that even though the telescope provides about 3 times the amount of magnification, using glasses and or a lower powered magnifier is used in addition to the telescope to get the best vision possible. After surgery, the patient is going to participate in approximately 3 months of therapy, which we'll talk about a little bit later. And the patient comes back about every 2 weeks just so that they can learn how to use their new vision. So in this slide, the implanted eye, so we talked about how the 2 eyes work differently. We talked about the implanted eye, the telescope eye, and the fellow eye. The implant eye is used for distances, intermediate, and near, so looking at the detail, where the peripheral, the fellow eye is going to be used for peripheral vision, which is the unimplanted eye, or the fellow eye. And then with vision rehab, that's where the process comes together to teach you how to use it and how to use your new vision. One of the benefits of the IMT, or the telescope, versus the, an external telescope is quite simple. It gives you a much larger field of vision, so it's about 20 degrees, versus an external telescope that you just hold up to the eye will go ahead and give you just about 8 degrees. So it's going to be much harder for you to see the detail of your environment with a handheld telescope versus something that's implanted in the eye, which will allow you to see a lot more context in your environment and easier to perform your ADL tasks as well as mobility. I think my clicker died. Maybe that means I'm out of time. All right, I'm dead in the water. Okay. Oh, here we go. Okay, so this is what the telescope looks like once it's implanted. So this is about 6 weeks post-op, and you can see here are the stitches from the incision that's made, and here is the telescope that sits right in the eye. So it really is not very detectable to anybody. So they're just going to say that you have a little twinkle in your eye. Yeah. Okay. So the IMT is not cataract surgery. It's also not a cure. It is really a way of maximizing your usable vision. And the team that is involved in providing the care for the IMT is consists of the retina doctor who will identify you, the cornea doctor who will implant you, the optometrist who works very, very closely with the occupational therapist in terms of prescribing the best glasses to use in conjunction with the IMT, and then the occupational therapist like myself, which will teach you how to function and carry out the goals that you have established with your new vision. There are a few trade-offs. With the IMT, you lose a little bit of peripheral vision in the implanted eye, and your vision tends to be a little bit dimmer, so patients may need a little bit more contrast. And just to move a little quicker, so basically what it really means is we take patients who have more profound vision loss, and then we take them and we move them over to more of a moderate, minimal amount of vision loss once the implant is in. And that will give somebody the ability to care for themselves or their others, because many of you who have macular degeneration may be care providers yourself. They are more able to perform activities of daily living and any of your leisure tasks. And so the process of having the IMT, you have to be, I think it's all in the screening. And in order to be successful, choosing the right candidate is going to be really important. And there are things that go into being a candidate. The amount of vision, which is from 2160 all the way up to 2800. And when you see the cornea doctor, basically they're going to look at the depth of the sac where the implant's going to go into, and both of those things are going to determine whether or not medically you are a candidate. And then you have the surgery, and then you go through your rehab, which is a team approach. I like to call it a 50-50. It's between optometry and occupational therapy, and of course the patient really needs to be compliant with the home exercise program. So this is the simulator, and we try it in the eval. So optometry, the optometrist will try the simulator to make sure that you have an improvement of about 5 letters, or 1 line on the eye chart to see whether or not the telescope will even be appropriate for you. And then as the occupational therapist, in our evaluation, and if anybody's interested, it's in the back, but you hold it up and you're going to determine whether or not there's really a good subjective and objective improvement in your functional vision for distance, for intermediate, and near. And the last thing is just a quick case study. So Mrs. G, after a multidisciplinary evaluation, her pre-op best corrected vision, and the right eye was chosen, was 2200. Her goals were to recognize faces during social interaction, watch TV with greater detail, read labels and prices while shopping, reading mail, and writing checks and cards. And that's the other thing, is you have to have very achievable goals. If you want to drive, or you want to play golf, or you want to be able to play softball, you're not going to be the best candidate, because those are not the most realistic goals. But if you are looking at spotting signs, or reading, or managing your checkbook, or cooking, or those are very, very realistic goals. And how did Mrs. G do? Well, you won't know because the clicker's broke, but essentially, so I'm going to tell you how she did. So her best corrected vision after the implant was 2100, and after 5 months of therapy, she felt comfortable walking to church, to local food stores in her community. She was able to cross the street and see the sign and see oncoming traffic. And lastly, she had a greater sense of independence and less reliant on her daughter.
Go, Mrs. G.
So it's great technology out there. It's not for everybody, but it's definitely something to consider if your goals are realistic and that medically you're a good candidate.
Thank you. Okay, how about that? You're the first crowd in our SupportSight seminar series that's gotten to hear this firsthand. So Allison did a great job. We are, Macular Vision Research Foundation is participating with SupportSight in helping to not only educate all of you about the options that are out there for you, and this could be one of them, but also talk with you a little bit more about a trial that they're, a clinical research study that they're conducting, et cetera. So this is what we do. We bring these opportunities to you, give you something to think about. Allison's going to be here to answer questions, right, in the lobby when we're done. She also has the simulator with her, so if you want to step up there and take a look at it, and it just takes a minute, right, Allison? And see how it might help you. So we're going to move on to our next, and she can answer any questions you have, I promise. We're going to move on to our next presenter. You're not going to want to miss it, so don't go away. I know it got warm in here, but feels a little cooler, right? Charlie Collins is a great friend of the foundation. He is Director of Professional Sales for our friends at VFO, who are also in the lobby. He is the former founder and CEO of Vision Dynamics, which is a company that he sold a few years ago. And he is also is CEO and founder of CCI, which is Charlie Collins International. Charlie is an international inspirational and motivational speaker. He's got an incredible story to tell, and we're going to bring him up. And as Allison mentioned, we know that depression, all of you, many of you may be feeling it, have felt it. You know, some days are good and some days are bad, right? And we know that macular degeneration affects people in a lot of different ways. So Charlie's here to talk to us about how you can help yourself and help others around you. Come on, Charlie. Yay.
All right. Ooh, that's bright. Hello. It is a little warm, but we can make it a little longer. So did you know the number one thing that limits a blind person is their vision? Good, you were paying attention. Did you know the number one thing that limits a sighted person is their vision? And where there is no vision, people perish. So I'm here to kind of help when we get all this information and we've been diagnosed or we've been living with it and maybe we felt stuck or we didn't feel we could get from where we are to where we want to be. I'm here to help that transition, to move from where we are to really what is possible living with low vision, any type of low vision. You know, because I believe that no matter what type of vision impairment you may have or the adversity and struggles you're facing, there is a solution and hope for each and every one of us, but it's going to come down to each and every one of us that we have the willingness. So when I was in 3rd grade, I was taken out of the classroom and sat in the hallway, and you know, they used to test the kids back then. They kind of did a quick little hearing test, showed you some pictures to make sure you weren't crazy. You had to say it's a cat and a dog, and then they did an eye test. And you looked at the chart and you read down, and then they said, fine, you can go back into class. But when I got to the bottom of the chart, the bottom line was harder to read. Matter of fact, I could barely read it, and they told me to stop fooling around. Just tell us what it says. Well, I am. But there was something interesting going on in my life at that time. I have an older brother and sister who also struggled a bit reading down lower on the chart. Now, they both were wearing glasses. I wasn't. So over the next couple of years, we went in and out of different eye doctors to try to figure out. We also went in and out of psychiatrists and learning, I don't know how to say that anymore. Not allowed to say learning disabilities or something. But so basically, did we have dyslexia? What was going on? So we were trying to figure this out. Well, we went to an eye doctor who said, you know, I think there's something actually going on in the eye, that you might want to head up to another place. And we headed it up to Mass Eye and Ear. So what we did as a family, now I have 4 sisters and a brother, and my parents, and all 8 of us jumped in the old green Plymouth station wagon with the wood paneling on the side, with the rear seat facing the cars following you, and the back window that could drop down and all that polluted exhaust comes right back in. It was the good old days. And it didn't form macular degeneration. So so we drove up to this Mass Eye and Ear, and we went into this room, and all 6 of us were tested for 2 straight days. Now we left after 2 days. They put us up in a hotel. It was fun. Played in the pool. I was young. No big deal. Went back to school. 2 months later, we were back up there. Same thing. Got a hotel, the pool, all the fun stuff. Got out of school, my favorite part. And at the end of these 2 days, the doctors came in and sat us all down. And I remember these 2 doctors looked like extreme scientists, like they were related to Jerry Garcia. And they had hair all over the place and their white coats on. But one of them explained something to us, and his tone was very grave. He said, I'm sorry, but 4 out of the 6 children have a very rare eye disease called juvenile macular degeneration, otherwise known as Stargardt's. Juvenile, I was one of those lucky 4. At age 9, and I can say, no, I was about 11, I don't know. I was too young. I remember thinking, wait a minute, where's the pill? Where's the pair of glasses, which I'm not happy I have to wear, but I guess I will. Nothing. We cannot do anything for you, these kids. We went back for another 1.5 years, every quarter. At the end of that, they handed us a piece of paper. Well, not us, my mother. And it said all the things we shouldn't do. We shouldn't snow ski. We should do this. We should not play certain sports. And you're gonna, because things in life are gonna slowly start getting worse because of our decreased eyesight. One of them was we weren't gonna be able to see colors or something. And my mother, we got up from that table, my parents were devastated. What do you mean you can't do anything for our kids? And she picked that piece of paper up, and she crumpled it up and threw it in the garbage, and we left. And I remember getting home and thinking, wait a minute. It was starting to hit me. You mean I'm not going to be able to be a jet fighter pilot? You mean I'm not going to be able to be a cop, a fireman? I'm not going to race motorcycles or cars? Most of all, you mean I'm not going to be like Magnum PI? I want a Ferrari and a gun. That's not good. This was the beginning of my depression and low self-esteem. And this lasted for years. At age 13, picture this. You're walking into school, you turn, and those of you, you know, can I ask again, because I didn't really see, of course, but how many of you in here have macular degeneration? Please raise your hand. All right, I'm not alone. Good. I'm not good, but I think you know what I mean. I always felt alone out in the world because it seemed like I was the only person with this problem. Everyone else was lucky. And I remember walking into school this day, walking down the hallway, and as Dr. Brilliant said, I could see everyone coming at me, but not really. I couldn't see their faces. I couldn't make out who the kids were, but I could hear the buzzing and everyone coming at me. Well, I don't like that feeling. And then I go in and sit down in the classroom. And the teacher's writing on the chalkboard. I could hear the clankety clank, and I could see the print up there and kind of make it out, but I can't really. And then it's turned to page 13. We're going to read. And a big thump in my chest. I already hated reading because I was slow. And you know what kids do to you if you read slow? Oh, they're brutal. What's the matter with you? You a little slow? Yeah, I believed I was. So off to gym class. Oh, good, gym. Walk in, hey everyone, today we're going to play dodgeball. Oh, that sucks. Not so bad throwing, but not so good being when the ball's thrown at you. But the worst part about that day was they were 2 captains picked teams, and I was the last person to be picked on a team. Well, why would you want the blind guy on your team? That didn't work for me. I went home that day, and I walked in, and my mom said, oh, hi, welcome home. How was school today? I said, fine. See, I didn't understand what was going on. I didn't know that I was full of fear, that I felt different than others, that I didn't feel like I fit in. I didn't feel good enough. I didn't know that I constantly was telling myself I wasn't smart enough. I just knew that it wasn't fair. So I told Mom it's fine. I'm not going to tell her all that other stuff. She said, I wanted to let you know you got a piece of mail, big piece of mail. And it has some stuff in it. I'm like, really? Finally, something good. So I went in the other room. Mail at 13 is not normal, I don't know. But I opened I ripped the thing open, and I dumped it out on the table, and I pulled out this big piece of paper, and it said, Charles J. Collins, in large print, you have been declared legally blind by the state of Connecticut. Can't wait to hang that. You know, today I'm grateful I wasn't declared illegally blind. If you read my book, you'll figure that path came later. So I was devastated. I felt those 2 doctors who I had a resentment towards, who couldn't fix me, they labeled me as less than a loser, a guy with a disease who was never going to amount to anything. At least that's what I thought they said. That's not what they said, but that's what I heard. Now my whole state knows that I'm not good enough. Oh, I got a free fishing license, though. You know, who's going to put the worm on the hook? So I like to ask, what's your piece of paper? I hung on to that for years. 10 more years. I fell into depression. I turned to alcohol, drugs. I turned to failing out of school. I turned into blaming you and my parents and God and my teachers and anybody around me. It was your fault. My life was miserable. Until I was at the jumping off point many times, wondering why am I here? So I'm cutting the lawn at a motorcycle dealership. I used to cut it weekly. I got credit there. Why would a legally blind guy want credit at a motorcycle dealership? Because he liked to ride his motorcycle. That's right. I was very good at it too. I rode a dirt bike. Trees can't sue you. I rode in the woods a lot. Something I could do. And I had been doing it for years. And my poor parents, what I put them through is just amazing. They're still alive. My poor mother would see me getting out, leaving the house and getting on a motorcycle and disappearing for the day. Well, there goes my blind son riding a motorcycle. I'm going to rest today. And after this day of cutting the lawn, it was a beautiful day. And finally, you know, the should thought was always, I should have done this, and so I always lived in the past of all my failures and mistakes, and my future was forget it. I didn't even like to look there because I knew it was never going to amount to anything, because in the present, I was struggling. So how could the future get any better? And I'm standing there, and the guy came up, and, I remember this. I mean, I can go to this memory where I was in a moment where I was present. I felt the breeze, the sun hitting my face. I could smell the fresh cut grass. Wow. And I got tapped on the shoulder. Whoa. I turned to look. It was another long, bearded, ZZ Top looking dude. He also was related to Jerry Garcia. Who here knows who Jerry Garcia is? Raise your hand. All right, you're getting something free. That was my higher power. So he asked me a question. This was Jimbo, the owner of the motorcycle dealership. He said, "Hey, Charlie, I was wondering if you would want to work here." But when he tapped me and asked me, "Hey, can I ask you a question?" I thought he was going to fire me. "You don't cut the grass good enough. I can't believe I gave some legally blind guy the opportunity to cut my lawn. I don't want you to do it anymore. You're no good at it." That's what my brain wanted. That's what it told me he was going to say. That's not what he said. He asked me if I wanted to work there. I was like, "What? Me? Don't you know who I am?" Now, I didn't say any of that, luckily. So I jumped on my scooter, and I rode home. Guess what? I walked in the house. "Mom, you're not going to..." I'm 23, by the way. I'm still with my parents. And I said, "You're not going to believe this. Jimbo offered me a job." She's like, "Oh, my gosh, you should take it. You're so good. You know motorcycles inside and out. Matter of fact, you bring that thing down in the basement, you strip it down to the frame, you rebuild it." I said, "Well, I mostly do that to make it go faster." But she's like, "You're amazing on that." And I'm thinking, I couldn't shut her off quick enough. She doesn't get it. She doesn't get it. I don't believe that. And, I remember going to bed that night, in the same bed I'd lied for 10 plus years, same bed I used to look up to the air and say, "Please, please take me. I don't want to wake up another day." Or, if it wasn't that, it was crying to sleep. Not this night. This night I fell asleep, slept well. Got up in the morning, jumped back on my scooter, rode up to the motorcycle dealership, walked in, blasted in there and said, "Jimbo, I guess I'll take the job, I'll take the job, Jim." "Okay, great." I said, "But hold on, you gotta know something. I'm legally blind." I wanted to say, "What are you thinking?" I'm legally blind, and I'm gonna need some help. Help. Me, 23, need help? Give me a break. Oh, I needed it, all right. And he said something so profound to me after that it changed my life. He said, "I knew you had something wrong with your eyes. I could tell all the years you've been coming in here. But that's not what's important to me. What's important to me is that you're passionate, you're enthusiastic, you love motorcycles, and most of all, you would be an asset to our team because I believe in you." Whoa. You believe in me, my mom believes in me. God doesn't believe in me. At least some people do. That was the beginning of the end for me. I took the job. I got help. Mike has it out on the table out there. I got this screen that displayed print. I hadn't read since high school, and I barely read in high school. I failed out of college. They make you do work. Forget it. That's hard. I can't see. I'm not going to go to school. School makes you do things with your eyes. So I got this machine. I put magazines, I put manuals, I put a pen to paper under it. I re-engage. Do you know what happens to the brain if you stop reading? Same thing with muscles. What do they get a little flabby, a little atrophy going on? The brain will do that. So if we stop because of macular degeneration or any adversity that we have this lie that says we can't do this anymore, the brain will just go to rest. And then it takes a little more to get it fired back up again. But it will get fired back up again. There's such a lie out there. One of them is you can't teach old dog new tricks. That's a bunch of BS. You can teach any brain's age new tricks. What it comes down to is, are you willing to do it over and over and learn it? Because you all know, none of you, I know it's the worst thing to say at a macular degeneration thing, but you all didn't drive at one time and then you learned how to drive for the most part and it became natural to you. But at first it was scary. Welcome to walking into living with low vision. It was very scary for me too. But now it's second nature. I took this job, I read, I ignited my brain. I couldn't believe it. I started selling motorcycles. The blind guy, I was killing it there. You know what happened in 3 short years? I moved from cutting the grass, I became the vice president, part owner of a multi-million-dollar corporation. The guy that almost died. How was that possible? Because I know each and every one of you, whatever you want to do for the remaining years of your life, because people love to tell me how old they are. I don't need to know that. I'm 92. Great. And you're alive today. That's all you got. I don't know if I have tomorrow, but I know today I can do the best I can. So I left that business because you ever have an inner prompting inside of you, something telling you there's something more in life? Well, my biggest transformation in life was surrendering to my eye disease, saying that little thing in the back of my fovea, whatever the heck Dr. Brilliant said, that thing is controlling all of me, and I'm miserable because of it. You know what the number one cause of blindness is? It's none of those eye diseases, it's thinking. Everybody that's stuck right now, it's because of you. You are creating your stuckness. There's nobody else doing it. Ooh, I didn't like learning that. I mean, I can't blame, complain, rationalize, justify anymore? No, not if I want to live free. So I went out and started a company. Yeah, a company that transformed the lives of over 15,000 people suffering with vision impairment. Most of them macular degeneration. They'd come in, they'd tell me their list of problems and their list of challenges. We'd turn them into solutions with the same types of things that Bill and Mike have out on the table. And other things. But just so you know, it's amazing what a magnifier, a portable magnifier, an optical magnifier, a desktop magnifier, what a machine that takes all the materials in Dawn's awesome packet. So I have advanced stage macular. I'm struggling to see. I have to have it so magnified it's tiring. Well, I could press a button, and this machine reads it back to me. Darn it, they removed all of our excuses with technology today. The only one is the one you create. So I ran a company for years, and now I wrote a book. Me. I wrote a book. Guess what it's called? Tripping into the light. That happens sometimes as visually impaired people. You know, I got off an elevator once, and I walked out, and it was the wrong floor. And I turned around, and I said, I'm not getting back in. They'll all know I'm a dum-dum. And I got off the wrong floor. So I was like, oh, my God, I made a big mistake. What an idiot. And I waited, and I hid, waited till the door shut, and then I pressed the button again. And I got back on the next elevator. And I'm going down. Somebody got off and said, oh, hold the door. I got off at the wrong floor. I'm like, God, how come that was easy for you? I don't think he's an idiot. So the more I get more transparent and tell on myself and laugh. There's still something funny about going out to eat and they put stupid decorations on food and eating it. This isn't food. It feels plasticky. Now, how am I going to get it out of my mouth without people noticing? Well, it's all good because, hey, I just take it out. Well, give me that cook. I got to teach him a lesson. So that's what I wanted to bring to you guys was a message that, Hey, I've been legally blind for 37 years. I've been macular probably since the day I was born, but it didn't present until about 9. And guess what? I'm grateful, I'm happy, I'm independent, and I'm free from the bondage of self because I focus on what I can do for others. Because the more I help you, the more my needs are all met automatically. Wow, it's amazing. So I just wanted to tell you that every day I don't think about having low vision. I don't think about blindness. I don't think about it's amazing how this automatically works now. And just know, a day at a time, wherever you, unless you're perfectly happy, everything's great, and you just came here to learn a little, have a couple donuts that aren't good for macular degeneration. Hey, thank you for coming out. You can't leave because the big guns are coming next, and it's very quick. We know, we have something to do, but we know that it's getting near the end. I just wanted to say one thing. MVRF, $22 million they've given to help find a cure so I can race a car. Not only that, they also are they know that by 2020, a conservative number of 20 million people will have this disease. And they want to find out and stop this. And I want to be a part of that. I hope you guys will be a part of that too. So,
Thank you, Claire. We're going to do a little exercise, and then we have some prizes to give away, and we'll get you out of here to grab a donut and talk with you.
kale.
No, I know the donut.
Grab a kale. Yummy.
You're right. Okay, Charlie.
All right, I'm Dawn. She's my Vanna. All right, you're all gonna fold your hands like you're gonna say a prayer or maybe punch someone. I don't know, whatever you do. Do you see? If you can't see what I'm doing, please, help the person next to you. All right, now I want you all to look down and remember which thumb is on top. You got it? If you need help with that, there's another program for you. All right, now separate your hands. Now, I'd like everybody that had their left thumb on top to please raise your hand high.
Left thumb on top.
All right, you guys are the better thinkers in the room. All right, hold on. Now, I would like the right thumbers to raise your hand really high. You guys are the sexier ones. Don't blush. All right, that's what the research says. So I want you to do something else. I want you now to do it again, but shift your fingers so your opposite thumb is on top.
Pray again and put the opposite one on top.
All right? We don't have all night. All right, how does that feel? Yeah, awkward, weird. All right, pull them apart. Go back to the other way. How's that? Yeah. Well, welcome to your comfort zone. There's 2 things I want to tell you. One is there's absolutely no research. It's okay. You're all better thinkers and you're all sexy. That's made up. But notice within you if anything came up when you heard you were the thinker and not the sexy one, and I didn't like that. That's one thing to notice. Number 2 is it's just a habit. And you've been living for whatever amount of years doing things a certain way, and then your eyes tell you you can't do that anymore. You need to find a new way. Guess what? There is a new way. But so with repetition over and over, it'll become a new habit. So if I took my hands and I wanted to be a right thumber, and I practiced 3 to 5 times a day for 20 days, 30 days, it would become my new habit. So trust me. Whatever adversity, whatever struggle, you want to read, write, you want to do certain things. Take it a day at a time. Keep practicing. I guarantee you'll master it. Thank you.
Yay.
Now we do a wrap.
Great, good stuff, right? Right? Good. Okay, we want to give prizes away real quick. And what I didn't say when I introduced Charlie is that he's also an author, as he mentioned. This is his book, Tripping into the Light. He does have some here. If you want to buy one, he'll sign it. Again, no pressure, but if you want to read it, it's a great story. And it's here for you. Also, let me just, before we give the prizes away, let me say a couple of quick things. I want to thank all our wonderful presenters, Allison, Dr. Brilliant, Charlie, everyone. Big round of applause. Thank you. I also would be remiss if I didn't just give my little list here. I want to thank the Delran Township for this lovely building. I hear that L&M Bakery did show up with some donuts, like we keep saying. There's a lot of them in the lobby, so grab one on your way out or stick around and have it while you're talking to each other. I want to thank the Delran Recreational Council. Thank you very much. Give them a round of applause. We've got Tyler Burrell in the back. Councilman Burrell, you may know him. He looks like he's 10. I know, but he's a great guy. And Colin Rafferty, they helped us set all this up and all that. Thank you very much. And I also want to remind you that I didn't get a chance to say this. Sometimes I talk about the research, but we had such a chock-full, packed evening. I will tell you that we are currently funding research in stem cell and gene replacement therapy, and they will, we believe, hold the answer. One of our scientists, I can say it publicly, she's the top. She's a rock star in stem cells. She's in New York. She's got MVRF funding right now, and in salamanders, they are regenerating the cells in the retina. So we are very optimistic, folks. We're not making this up. There's a lot of clinical trials out there for a pill instead of a shot. We're funding a lot of research right now in dry macular degeneration, because if we cure dry, there won't be wet. The research community figured that out about 10 years ago. So there's a lot of great stuff going on, and check out our website, stay in touch with us. We're telling you about it, and we're funding it. So I want to leave that note. It's really important, because research makes medicine. The only way that Lucentis gets, or that cancer drug gets to help you, is if there are researchers figuring that out. So that's my thing. Thank you. Lynn, who's got the prizes?
I got my own.
Yours?
Okay.
Raise your hand. Maggie will bring it around.
The first person who's going to win the book is Phyllis Popple. Phyllis.
Yay, you're 90, Phyllis, and you can read.
Charlie signed it, and you're going to get your picture taken with Charlie.
Yay.
The second one is Cecilia and Edwin Shin.
Oh, in the front here. Is that okay? Good.
Okay, they want a backpack, and inside the backpack's large print writing paper. And the third prize is Rosemary Smith.
Where's Rosemary?
Rosemary Smith, did she take off?
Okay, got to be here to win.
All right, you have to be. How about Elizabeth Lucas?
Okay, Elizabeth, over here. Great.
Elizabeth.
So congratulations, everyone. We encourage you to just respond to the surveys real quick. Our sponsors want to know feedback. That helps us a lot to hear what you thought of the program, so we appreciate that. I want to thank my awesome team, Lynn and Maggie and everybody involved. Go see the people outside from Accessibility, or I'm sorry, I said it wrong, Mike. VFO. And Alvina Wilson, we would only be here last but not least because of her. She got us here, and let's give hard work and passion, and we love you.